This is chapter 11, baseline vital signs. First thing I want to talk about is the various types of vital signs that we obtain on patients. Now, we use the acronym PROBELLSS, and this covers pulse, respirations, oxygen saturation, blood pressure, pupils, in this case eyes, lung sounds, level of consciousness, skins, and their blood sugar level. The very first set of vital signs we obtain on a patient when we initially encounter the patient is called our baseline vital signs. And those vital signs we obtain that first time guide us throughout the call, because now we have this place to start. So throughout the call, we're reassessing the patient, we're taking our second, third, fourth set of vital signs, and we can tell, we can watch this trending. Are they getting better or are they getting worse based on these vital signs we obtain? Now, per National Registry and truthfully out in the field as well, is legally the minimum set of vital signs that you should document on every patient, whether they're dead or alive, whether you transport them or you don't transport them. You should document clearly 2 complete sets of vital signs that are pertinent to the patient's condition. Now, there are some times when you'll get a patient that you'll get your first set of vital signs and they refuse any further physical contact, or they might just run away. So all you have to do in this case is document your only set of vital signs, and then document in your narrative of your paperwork why that second set was not obtained. Also with this is not every single patient that you're going to encounter needs all of these parameters checked. For instance, you got a person who twists their ankle down at the beach. Well, pulse, you want to check definitely. Respirations, you'll need to document. You'll definitely need a blood pressure, a level of consciousness, and then their skins. That would be all you probably need to document on a patient like that. But if someone's short of breath, well, then you'd also want to document their lung sounds, their oxygen saturation, and if they are altered, they're not alert or they're disoriented or unconscious, then you definitely want to get a blood sugar test as well. So these vary a little bit depending on the patient's presentation and how the call goes. Now your equipment, you have a blood pressure cuff, which I'm sure you already purchased, a pulse oximeter, stethoscope, glucometer, pen light, watch, pen, and this should be more than enough to get a complete set of vital signs on any patient. Now, for level of consciousness, we use the acronym AVPU. So it stands for alert, verbal, pain, and unresponsive. So when you walk in on a patient, when you're approaching a patient, you're doing that initial impression. You're looking at what do they look like? Are their eyes open? Are their eyes closed? Do they appear to be aware of my presence as I walk into their space, their personal space, or into their room? If you walk in the room or you walk up to the patient and their eyes are open, then they're automatically alert. So it means they're alert to their environment. But it does not mean they're oriented to person, place, or time. So someone can be alert in the sense that their eyes are open, but it doesn't mean they're going to know where they are right now or even the time of day, month, or year. So we notice these eyes open spontaneously, they're alert. If we walk in the room or we walk up to the patient and their eyes are closed and we say, "Hi, sir, my name's John, I'm here to help you," and their eyes open and they look at me, well, then now they're V on the AVPU scale. They respond to verbal stimuli by opening their eyes. At that point, you could ask, "What's your name? Where are we right now? And what time of day is it or what month is it?" You walk in the room, the person's lying there, their eyes are closed. Sir, wake up, sir." There's no response. You apply painful stimuli by a trap squeeze, and they open their eyes and they look at you. Well, now they're P on the AVPU scale. They respond only to pain. They open their eyes, they look at you, they're aware of your presence, basically. So what could you do? You could ask them again, "Sir, what's your name? Do you know where we are right now? Do you know what day it is?" So anytime you get a response like that where they seem to be somewhat alert to the point where you can ask them questions and ask them those 3 basic questions. Now, obviously, if their eyes are closed and you say, sir, 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 wake up, they don't wake up. You try painful stimuli, they're still not responding. Well, now they're unresponsive to pain. So every patient, whether they're awake and alert, whether they're unconscious, kids, old people, whatever it is, everyone we do an AFPU on. And how we would document this is we would want to document how they're oriented. So their eyes open spontaneously, so they get A on the AFPU scale, and they're oriented, they know their name, they know the place they're at right now, and they know the time of day or week. So now they're alert and oriented times 3. There's 3 parameters, person, place, and time. So they're alert and oriented times 3. And now another tool we use is called the Glasgow Coma scale. And this was originally designed by neurosurgeons to grade coma, level of comas on people with head injuries. Per the County of San Diego, every single patient we encounter in the field, whatever the age, we need to document at least 2 complete Glasgow Coma scales. It's required by the county, and pretty much every other county that I know of requires the same thing. It's broken up into 3 parameters: eyes, verbal, and motor. And eventually, at least by midterm anyway, I would assume you probably already would have memorized this, but at some point you will have to memorize this. So eyes should look really familiar from our just previous conversation a couple of minutes ago. Alert, verbal, pain, and none. So this essentially is AFPU. So if their eyes are already open as you walk in the door, they get a 4. If their eyes open to your voice, they get a 3. If they open to pain, they get a 2. And if they don't open at all, they get 1. Now, verbal should also look somewhat familiar. Remember I talked about being oriented earlier. So if you walk up and you are talking to the patient and they say, my name's John and I'm at home and it's Tuesday, and all the answers are correct, then they're oriented, so they get a 5. If they know their name but they don't know where they are, or they don't know the day, month, or year, or they're acting confused, well, then they get a 4. If you ask them a question and they use inappropriate words, you'll see this a lot with stroke patients. People who are having strokes will sometimes, they'll be able to speak, but they can't find the right word to use because of the damage to their brain from the stroke. So you might say, "Hi, sir, what's your name?" And they might say, "Confusion, Carmen Gia, Volkswagen, paint," or whatever it might be. They might use different words or inappropriate words. They would get a 3. If the person's just mumbling, kind of like I am right now, they would get a 2. And of course, if they are nonverbal, they get a 1. Now with motor is essentially, do they follow commands? So as you're speaking to the patient, they're talking to you, or they're aware of your presence. You might ask them to raise their hand or to point to where they heard. Well, if they can do either of those, they follow commands, so they would get a 6 on this scale. If they can't do that, if they can't follow commands, and you apply painful stimuli like a trap squeeze, and if they reach up and they try to push your hand away, well, they localize to pain. They would get a 5. If you apply painful stimuli and they try to withdraw from it, so their body moves away from the pain, they would get a 4. Now, decorticate posturing is also known as flexion posturing, and both decorticate and decerebrate posturing are indications of serious head injuries, brain injuries. And unlike the person who follows commands, unlike the person who localizes or withdraws from pain, decorticate and decerebrate posturing is an involuntary response from the brainstem. So when someone has decorticate or flexion posturing, or decerebrate, which is extension posturing, which is another term for it, then I know that their brain is swelling, and I know they have damage to their brain and even their brainstem. It's a very serious injury to this person. So what that looks like, what decorticate looks like, is it's called flexion. When you flex your muscles, your arms kind of flex up towards your chest, your forearms. And you'll see their arms flex up towards their chest. Their eyes will roll back. Their legs will kind of do the same thing. They'll kind of bend a little bit, and they'll arch their back. It's not as, what's the word for it? It's not as obvious as I'm trying to describe it. It can be very subtle when you see it, but that's kind of the idea. So you're flexing towards the core, essentially. Now, cerebit is the opposite. It's extension posturing. So their arms will come down and straight out at their sides. Their legs will go straight out. They'll point their toes. They'll roll their head back and then roll their eyes. And again, this is usually the ones I've seen in the field are really subtle, to the point where you could actually miss them, these particular types of responses, if the person were fully clothed or had heavy clothing on. So you have to look for them carefully. So you're going to apply stimuli. You're going to squeeze their traps to create that painful stimuli, and they might shrug and flex a little bit. That would be decorticate, or they might kind of try to extend their body a little bit, and that might be cerebit. If they do not respond at all to pain, then they get a 1. So if you add up all these numbers, the highest score is 15, 4, 5, and 6. They're alert, their eyes open spontaneously, they're fully oriented, and they follow commands. They get a 15, which is the majority of our patients out there that we encounter. So actually in the field, this is pretty easy. And the least, of course, is a 3. Now, I have to warn you about this, is you can be dead and have a 3. You can be a Glasgow Coma scale of 15 and have a gunshot wound to the chest. Obviously, just because the Glasgow Coma scale is low doesn't necessarily mean that you're critically injured. Think about it this way. I'm sure you've seen drunks out there, someone who is really, really, really drunk. They're going to have a low Glasgow Coma scale, even to the point of being a 3 sometimes. They're so out of it, they're unconscious. Well, is he in danger of dying? Probably not, but he might be in danger of a hangover tomorrow morning. So you have to take this with a grain of salt. This is a tool we use to grade patients, seriously injured patients usually, and primarily in relation to head injuries. But remember, everybody you encounter for the County of San Diego, you'll be required to document a Glasgow Coma scale. Now, pulse points. So there's various areas of the body where an artery comes close to the surface and it kind of overlies a bone. So anytime you get an artery that kind of goes over a bone and is close to the surface, we're able to access it and feel it. So the obvious easy ones are the radial pulse, which you can see is on the thumb side of your forearm, just behind the thumb there. The brachial artery is in what's called the antecubital space, that little bend in the elbow on the inside of your elbow bend right there. That's called the antecubital space. And the artery is on the medial side, so it's on the inside of that arm. As you can see from the diagram here, there's a brachial artery here you can feel, and of course you have the carotid artery in the neck as well. These are probably the 3 primary pulse points that we're going to check initially upon contact with the patient. Now, usually a radial pulse is obtained on most every patient, an awake, alert patient, a medical patient, a patient who's talking to us. More than likely, we would obtain a radial pulse to determine how fast the pulse is and how strong it is. If it's a child, and an infant especially, you might obtain a brachial pulse, and that's on the inside of the bicep, on the medial side under the bicep muscle. And then if they're unresponsive, they're lying there and they're not responding to your presence, then a carotid pulse, you could check that as well. Now, for the purpose of National Registry and for the purpose of the class, all pulse checks are 30 seconds in duration, and that's why you need a watch, essentially. We check rate, rhythm, and quality. So we're going to count for 30 seconds. We're going to get a pulse rate, and they're going to multiply it times 2 to obtain their pulse for 1 minute. So we're doing a sampling, a 30-second sampling of a 1 minute pulse, essentially. Now, in the field, you're going to see other things happening. A lot of EMTs, they go 6 seconds and multiply times 10, or they go 10 seconds and multiply times 6. But anyone out there who has ever done any kind of statistical analysis or any type of sampling will know the bigger the sample, the more accurate it's going to wind up being. So for our purposes here, we're going to use 30 seconds and multiply times 2 to get pulse rate. Now there are times when you are, even in the field, you're going to check for a full minute. And most commonly, this is when you have grossly irregular pulses. These pulses are not thump, thump, thump. They're all over the place. They're hard to count, and you might check for a full minute. Or maybe the person has a really, really weak pulse, and it's really hard to feel. Again, you might check for a full minute. Now, obviously, if they have other critical things going on, other people will still be working on the patient, do ventilations, whatever, bleeding control, whatever it might be. But if you really want to get an accurate blood pressure, pulse, then you'd want to check for a full minute. But we only do it rarely when we absolutely need to. So rate is obtained. Rhythm is regular or irregular. Young women have sometimes what's called a sinus arrhythmia, and they have slightly irregular pulses, and that's totally normal for them, and they outgrow it after when they get older. Old people get grossly irregular pulses from something called atrial fibrillation. Their heart is damaged and they get this irregular pulse. So sometimes this person has an irregular pulse. It's normal for them. If you have any questions, well, you ask the patient, sir, is your pulse normally irregular? Is it normally not beat regularly? And then quality is going to be kind of subjective, and it's going to kind of be based on your experiences. But you're feeling the pulse. It should be easily felt, essentially. Now, how you do this is you locate, let's say we'll go with the radial pulse right now, but you take 2 fingers, more than likely your middle and index finger of your hand, and you place it over the pulse point that you want to obtain, and you just push in gently until you feel a pulse. If you push in too firmly, you could actually push in so firmly that you will occlude the pulse, especially in older people, in elderly population. So all you're doing is you're gently pushing in over the site of that pulse point until you feel a pulse. You push down, and if you feel something, then you start to count, go through your process. So again, we want to know, so if it's easily felt, it's easily found, I would probably call that a strong pulse. If it's kind of hard to locate, it's kind of hard to really to find it, you can feel it, but it's kind of not fully there, then I would call that weak. And thready means really fast and really weak. I don't know if anyone's ever heard a sewing machine run. And that's why they call it thready, essentially, threads and sewing machines. But thready means just very rapid and very weak, and this is a sign sometimes of someone who's in shock. So respirations, we're going to do the same thing. We're going to check rate, rhythm, and quality. It's the same parameters, just a little bit different. We're going to count respiratory rate for 30 seconds and multiply it times 2. Same thing we did for the pulse. And again, if this person's breathing really slow, or really irregular, or really super fast, at some point in the call, to get an accurate count, you're going to have to check for a full minute while you're doing maybe something else in the process. The rhythm is regular or irregular. Now, pretty much everyone's rhythm should be regular. People who seriously injured people, gunshot wounds, people with chest pain, shortness of breath, everyone, whether they're conscious or unconscious, normally have regular respirations, rhythm anyway. There are some cases where people get irregular pattern respirations, and this primarily has to do with brain injury or a brainstem injury. If you think about your anatomy and physiology lecture, you think about what controls your breathing, it's in your brainstem. So the only time you really see irregular breathing in young children and adults, not so. I mean, there you will occasionally see irregular breathing in newborns, but that's because obviously they're newborns and they take time to develop, and in a month or so they're breathing regularly. But I'm talking about young kids and us and elderly people. Everyone should be breathing regularly. If they have an irregular breathing rate or a pattern breathing rate, there's different kinds of pattern breathing rates out there. There's Kussmaul respirations, there's ataxic respirations, there's Cheyne-Stokes respirations. All these have these weird, obvious patterns that are just they're grossly obvious. You can't miss them. That's bad. That's a brain injury or a brainstem injury. And quality is somewhat subjective. Labored respirations. I know you learned about accessory muscle use. Now remember that normally healthy breathing is unlabored and effortless. So right now you're listening to this and you're breathing, you're not aware of it, it just happens kind of in the background a little bit. And so when someone gets short of breath, if they become hypoxic, their brainstem, their chemoreceptors kick in and they start to use more muscles, and they start to make those muscles contract harder and faster to try to keep up with this loss of oxygen, whatever's going on with the patient. And what that does is it makes the person, when you look at them and you're assessing the patient, it makes it look like this person's working hard to breathe. That's labored respirations. And that's telling you that this person does have some type of fairly serious respiratory thing going on. So again, the breathing should be full and effective. The chest should rise and fall easily and freely. And the adequate tidal volume. On average, a person will inhale about 500 milliliters of air with each ventilation. So that's a normal rise and fall of the chest. So you look for, is it labored? Is it unlabored? Does it have adequate rise and fall of the chest? That's the quality of their breathing. So rate, rhythm, and quality. So you count for 30 seconds, multiplies times 2, regular, irregular, unlabored, or labored respirations. Skins are a great tell for us. Skins respond to all types of things going on inside the body. Now, normally we're all pink inside and out. So if you look inside someone's mouth, you look inside their lips, you look underneath their eyelids, we're all pink. No matter what our skin color is outside, we're all pink inside essentially. So pink means we have enough blood coming back from the heart to the tissues, reperfusing our skin to show us this literally is this pink color. If a person's pale, unnaturally pale, I mean, some people are just naturally pale, but you could always ask the patient, sir, you look a little pale today. Or you could ask the wife or the girlfriend or the husband or whatever it might be, sir, I noticed your wife looks a little pale. Is that normally her color? Oh no, that's new for her. Pale means there's less blood returning to the skin. And this can be a sign of a number of things, but if you think about how when we talked about alpha and beta products of adrenaline, how it causes vasoconstriction and it shunts blood from the skin to the core during times of shock. Well, pale skins could be a sign that this person is going into or already is in shock. Cyanosis, or being cyanotic. Now, cyan is a color of blue, and osis is an abnormal condition. So what cyanosis means is it's an abnormal blue color. Look at the cat right there, the blue tongue. Now again, we're all pink inside, so you might have to look, if you have a dark-skinned person, you might have to look in their mouth or under their eyelids or their nail beds to see cyanosis. Another thing about cyanosis is you need to have light, ambient light, to see color. I mean, this is just the way it is. I mean, color is light. You can't see color in a dark room. So to really truly see the blue, this cyanotic blue color that people get due to hypoxia, you need to have a well-lit room or be outside or in the back of the ambulance. So you might have to hold off on that until you get the person out to an environment where you can, better assess them in that way. Jaundice is a yellowing color of the skin, and that's caused by liver failure. So it's something you'll see out in the field more than likely. An ashen color is a gray. This is associated primarily with cardiac patients. They get this literally, it's a dull gray look to their skin, and it's a bad sign. It means they have a serious heart condition. Temperature, we should all be warm, 98.6. Now, obviously, infants, newborns are slightly higher, 99, 99.2, 99.8. But on average, young children and adults, 98.6 warm. And of course, if someone's cool, that could be due to shock, or it could be due to environmental exposure, like being out in the snow. Heat or being hot can be a fever, or it could be in the heat out there. You're out in the hot days, you're doing a marathon, or you're digging ditches and you're overheated. So we're going to check temperature. Moisture. Our skins generally should be dry to the touch. If they're clammy, if they're diaphoretic, diaphoresis or being diaphoretic means you're just dripping with sweat. Now, again, falling back on the release of adrenaline, alpha beta products. Well, some of the side effects of the alpha beta release is these cool, clammy skins, or these cold, diaphoretic skins. Remember that some of the things that the alpha products do is they cause vasoconstriction, moving that blood out of the skin to the core of the body to protect the vital organs. Well, if you draw the blood away from the skin, it makes it cool, and of course it also releases sweat, so it makes it clammy or even diaphoretic. So this is why people get pale, cool, sweaty skins when they go into shock, is because it's a side effect of the release of that adrenaline to trying to keep them alive, essentially. We also have something called capillary refill time. Now, the capillaries are the little tiny microcirculation that are in your skin, and they surround all of your organs and all of your cells to provide that perfusion of oxygen and carbon dioxide. But the capillaries in our skin, we can blanch them. We can actually take our fingers and we can squeeze the tip of your patient's finger. And what that does is it blanches the blood out of the tip of the finger. And when you let go, that blood should rush back very quickly. Now that's the refill time, how long it takes for that blood to go back into the area you just squeezed. You can kind of see from this picture right here, this person pushed down on this child's forearm, it looks like. And you can see how it blanched that white area. And what they're counting right now is how long it takes for that white area to disappear, to return to pink again. On children and adult males, cap refill time should be less than 2 seconds. On females, it should be less than 3 seconds. And on elderly people, both male and female, it should be less than 4 seconds. So 2 seconds for infants and adult males, 3 seconds or less for adult females, and less than 4 seconds for the average elderly person. Cap refill times can be skewed by all kinds of things. It's most reliable on little kids. Kids are usually less than about 4 or 5 years of age. It's not very reliable if the person's really cold, like they've been immersed in ice water or they've been caught out in the snow. It doesn't work very well on people who are in shock because they just don't have that blood flow to their extremities like they normally would due to what we talked about earlier. So it's not super reliable, but again, it works pretty good on infants and toddlers, kind of that age basically. So eyes. So this is why you have a pen light, and you're going to be indirectly shining light into the patient's eye one at a time, and you're going to cause the pupils to react. Now, when you walk into a darkened room, your pupils normally will dilate to let more light in the back of the eye so you can see better. When you go out into the sunlight, the pupils constrict to reduce the amount of light because obviously it's lighter. There's more ambient light. So when you apply a light to someone's eyes, they should constrict the pupils. I mean, so what we look at is how do the pupils respond to our light source. Now, pupils should be equal. Both sides should be the same size and basically the same shape. And they should respond to light the same. Now, we have something called consensual response. If you apply light to your right pupil, your left pupil follows exactly the same. If you apply to the left pupil, the right pupil will constrict as well. This is called consensual response. So what we look at is does each pupil constrict at the same amount, at the same rate, and do both pupils constrict at the same time with this consensual response. So what we do with this is, and you probably looked at your pen light already, but you'll notice on the side of your pen light, you have these little measurements in millimeters, little round blue circles. So first thing you're going to do is you're going to hold that pen light up next to the person's eyes, and you're going to get a base measurement of the size of their normal pupil. Most adults, usually around 4 millimeters or so is average size. Then you're going to apply the light, and then you're going to see how much or when, how these things constrict. These pupils should constrict equally at the same time and at the same rate. If one pupil's bigger than the other, or it doesn't react like the other one, that's abnormal. Now, there are people who have naturally unequal pupils. They're born that way sometimes. I think it's called anoscorsia, I believe is the term they use medically. Or they had some kind of eye surgery, or they have a glass eye. So if the person's awake and talking to you and you notice their pupils are unequal, just ask them. Say, sir, I noticed that your right pupil is a little bigger than your left pupil. And I guarantee they'll say something like, oh, I was born that way, or I had surgery, or whatever. Now, if someone is in cardiac arrest and their body is no longer really functioning, it's not really producing the actin and myosin, and the muscles aren't really working anymore. What happens is the pupils relax and they dilate and they become fixed. So you apply light to them and they just stay big, like 7-8 millimeters, and they don't constrict because they don't have that response anymore because they're dead. Sluggish pupils, you apply light to a patient who is low on oxygen, and you might notice it takes a little longer than normal for that pupil to constrict. And again, the muscles that cause that constriction are low on oxygen, and they're just kind of not wanting to work right now. But they will eventually constrict, but it might take a few more seconds than it normally would. If you have an unconscious patient or a semi-conscious patient, and they've hit their head and their pupils are unequal, that's a serious finding, because if you think about it, if their brain is swelling and it's pressing on the optic nerve, that pressure on the optic nerve can actually cause that one pupil to dilate, like you see in the picture right here, where you see the one pupil on the right is much larger than the one on the left. And that's indicative of someone who has intracranial hemorrhage or some kind of swelling going on in their brain or in their skull. Dilated pupils, very common with alcohol intoxication and also drugs like amphetamine-like drugs, cocaine, methamphetamines, things like that will cause dilation of the pupils. Big pupils, 8 millimeter pupils. It's kind of funny to watch. Constricted pupils, you see this predominantly with opioids. And this is heroin or codeine or there's a number of narcotics out there. They all cause constricted pupils. So these are really tiny, like 2 millimeter tiny pupils. And when you apply your light to them, they do not constrict anymore. So they're kind of fixed at that really tiny size, about 2 millimeters or so. So just general idea about pupils. Lung sound. So we have these auscultation sites. Everyone gets assessed these 6 fields. You have 4 in the front and 2 in the back, essentially. So the first one is your second or third intercostal mid-clavicular line. And so if you put your finger on their clavicle and you run down to the first kind of indentation, that's their first intercostal space. If you go over the second rib, there's your second intercostal space. You go over your third rib, that's your third intercostal space. So somewhere around there, that's where we want to place the diaphragm of the stethoscope to listen for this person's lung sounds. We always want to check bilaterally, so we're going to check the second or third intercostal space, check one side, have them open their mouth, breathe in and out, do the other side, in and out, and then when you're done with the second or third intercostal, you move then to the fourth or fifth intercostal space, and this is mid-axillary. Mid-axillary is under the armpit. It's the line straight down from your armpit, essentially. So you're going to go down, you're going to count. So your first rib is right underneath your clavicle. So your first rib, there's your first intercostal space, second intercostal, third, fourth, fifth. You work your way down. So roughly about the level of the nipple line is you're gonna take your scope and slide it under their armpit around the level of their nipple line, and you're going to listen at the fourth or fifth intercostal space. Again, have them open their mouth, take a deep breath in and out, breathe in and out, check both sides bilaterally. Then you'll lift up their shirt. Well, you would have done anyway, lift up their shirt on bare skin, but lift up the back of their shirt, and you're going to check subscapular. The scapula bones are those kind of triangular bones that make up a part of our shoulder girdle, and on your back right there at the inferior angle at the base of those bones, where the bones kind of make a little wedge, you're going to listen right there at subscapular. Do the same thing bilaterally. So you should have 6 fields, and you should have listened to all 6 fields and compared left and right to see what you hear, essentially. What you should hear if they have healthy lungs with no problems is clear lung sounds, which means you'll hear air moving in and out. It's like rushing through tubes or tunnels, which is exactly what's kind of happening. If you hear a bubbling sound or a gurgling sound, that's called rhonchi. And that's associated primarily with an infection, some kind of bronchial infection, or they could have aspirated food. Maybe they were eating food and they passed out or had a seizure, and in the process of them seizing or going unconscious, they inhaled the food in their mouth, and now it's in their lungs. So this is not an uncommon thing you'll hear out there. Rails are crackly sounds in the bases of the lungs. This is down at the base of the lungs, and this is edema. This is fluid. Rails can be caused by a number of things. Most commonly, it's caused by left-sided heart failure, which causes blood to back up into the lungs, leading to these crackles or these rails in the base of the lungs. This can also be caused by drownings. Someone inhales water into their lungs. It floats down to the base of their lungs and gets agitated. It makes that crackly sound we call rails. Wheezes, that's bronchoconstriction. So as those bronchial tubes get narrowed and get filled with mucus, the air passing through those tubes accelerates, and it makes kind of a musical wheeze sound. And it could be inspiratory or expiratory, so you might hear them as they breathe out or as they breathe in. But either way, when you hear wheezes in someone's lungs, it means they have constricted bronchial tubes. Asthma attacks, heart problems, some being exposed to chemicals. There's a lot of reasons why people have wheezes. Listen, just be aware that if you hear wheezes, it means there's less oxygen, less air being passed through down into the alveoli. So these people are probably working hard to breathe. You're going to probably see accessory muscle use, probably going to see labored respirations with them. Another tool we can use is called pulse oximetry. So this is an older model, but essentially it's the same thing. That little clip thing goes on your finger. I've seen them. They also can go on your ear, the bridge of your nose, all different types are out there. But this one's probably the most common you'll see out there. It goes clips on this person's index finger. And what it does is it samples the amount of red blood cells that have oxygen molecules attached to them. Now, as you remember from your anatomy physiology class, each red blood cell has 4 receptor sites, 4 hemoglobin sites to hold oxygen. So if every single red blood cell in your body were filled to capacity, then that machine would say 100%. But realistically, that's not what happens. The average person, probably about 95 to 97% of their red blood cells are occupied, the receptor sites anyway. So normal pulse oximetry reading on an average healthy person, somewhere between 95 to 98% is pretty normal. 100% is not normal. And of course, anything below 94% is considered to be abnormal as well for the average person anyway. What's nice about this is obviously it can give you a pretty good baseline of what's going on with the patient. Not everyone who's hypoxic shows obvious signs of cyanosis and the things that we taught you anyway. So it's a good baseline for us. It can be skewed by cold, if their extremities are really cold, if they have fingernail polish on, if they have poor perfusion due to shock, because it relies on the tip of the finger, which is probably going to be pretty low on oxygen or flow of blood if they are in shock, it probably is not going to get a very good reading. So they're not super accurate, and they're not going to be able to tell you what's really going on, essentially. What you might notice on the screen of this particular pulse oximeter, on one side of the red screen, it says SpO2, and that is the partial oxygen percentage. That's where the number 98% will show up. And the other side, there's a little heart icon, and that's their pulse. And that pulse will show up. Now, this is not a pulse checking device. And the reason why the pulse is there, why it shows up on the screen, is now what you can do is you can feel their pulse. Take your 2 fingers, put your fingers on their radial or brachial or carotid pulse, and if the pulse you feel under your 2 fingers is roughly the same as you see on this monitor, then you can pretty much say that that number, that SpO2 number, is probably reliable because it's sampling the correct amount of red blood cells, and it's able to sample enough to get an accurate reading. If you're getting a oxygen saturation level that doesn't look good or doesn't seem right for the patient, and the pulse that's showing up on the monitor is different, grossly different than the pulse that's on the patient, then this thing's not reading correctly and cannot be relied upon to give you an accurate reading. So use that as a way of determining whether this thing's working well or not. We have a whole class on checking someone's blood sugar. You're actually going to learn this skill, or you probably already have at this time. This is a great tool for us. EMTs can take blood sugar checks now in the state of California on standing order, and every ambulance in the state of California has to have one of these on it. So you will be doing this, and it's, again, a great tool for us. Per National Registry, the normal range of blood sugar in the average person is from 70 to 140 milligrams per deciliter. Depending on where you work, the definition of hypoglycemia can change. So for the county of San Diego, the definition of hypoglycemia is any blood sugar less than 60 milligrams per deciliter. Again, this is a person who's going to have some type of symptoms. That's why they called you. They're going to have an altered mental status. They're going to feel weak, dizzy, out of sorts, sweating, whatever it might be. you're going to suspect possible diabetic problems. You're going to take their blood sugar. If it's below 60 milligrams per deciliter for the County of San Diego, you could then administer the oral glucose based on the county protocol. Blood pressure cuff and stethoscope. Okay, so I know you guys probably bought one of these, and they probably look somewhat similar to what we have here. I wanted to point a couple things out. There are different size BP cuffs. There's an infant, child, adult, and then big. They call them thigh cuffs, which means they're big person cuffs. We carry 3 sizes on the ambulance, which we carry child, adult, and oversized. We do not carry infant because they're not reliable for us. And you'll see those in the hospital or in the clinics. So you can see from this one picture on the left, the ABC picture, there actually is a range printed right on the BP cuff. And you can see where it says index, that line right there, that A line, that white line going down, that's the edge of the cuff and the arrow right there. B and C is the range. So when you wrap this thing around the patient's bicep, and nice and snugly like you're supposed to, that index arrow should fall within the B and C range. If it's way past that, it means the cuff's way too big for the patient. If it's barely making it and it's outside the range, it's probably too small for the patient. So it needs to fall within that range. And so again, most people, the adult size cuff fits most everybody. If you have a person with gigantic biceps, or they have no arms and you can only take a blood pressure on their leg, well, you might need the thigh cuff possibly. But again, that's the range you need to know about. On the other picture in the upper right, it's hard to see, and I do apologize, but there's a little line with a circle and it says artery. So when you apply a blood pressure cuff, and they vary from manufacturer to manufacturer, when you apply your BP cuff to someone's arm, you would have already located the brachial artery, which again is on the medial side around the antecubital area of the crook of their elbow, so to speak. And so what you want to do is you want to align that little arrow that says artery to where you found the artery on the patient. That's so that when you put the cuff on, it's oriented so that the bladder inside the cuff is oriented to the brachial artery. So when you do inflate the cuff, it puts pressure on the brachial artery and cuts off the flow of blood, allowing you to obtain a blood pressure. So it's really important that you put the blood pressure cuff on correctly, the right range, and also that arrow points towards the artery that you're trying to check the blood pressure on, left or right. Some cuffs will actually have artery left and artery right. Whatever it is, just follow whatever you have that you bought. Now, when it comes to stethoscopes, this probably is the one that you wind up purchasing, unless you're rich and you bought like a Littman or something. But pretty much all scopes have double heads, like you see here. And to use one side or the other, you have to flip them. They actually turn, they pivot around. Make sure that you're listening on the right side. Now, the larger diaphragm there that's more for low tones. So the larger one is used for lung sounds, and it's used for obtaining a blood pressure. For us, the smaller one is higher tones, and it's used primarily for children. I use it for checking for stridor. If someone has stridor is found in the upper airway, up in the neck. It's a high-pitched sound. It's a little better for that. But to do that, you have to literally flip that head 180 degrees to turn the one side off, turn the other side back on. Also with the earpieces, they usually come with different, like a packet of different soft ones versus firm ones. Find the ones that are comfortable for you. Take off the bad ones, put on the nice ones, whatever your choice is. And also those metal ears right there, you can actually turn them. You can grasp them gently, and you can twist them inside and out essentially. So you want to make sure that those earpieces, when you go in your ear, they actually face slightly forward, like towards your eyes. Because if you ever look in someone's ear canal, the ear canal doesn't go straight in. It actually goes in anteriorly. It actually it kind of bends towards the front of the body, and you want those earpieces to mimic that angle of the ear canal. So look inside someone's ears, and you can see how it kind of goes towards the anterior portion of the body. So just gently bend those. If you don't do that, you just stick them in the way they come out of the box, you're going to occlude the opening and you're not going to hear anything. So there's two types of blood pressures we obtain. One's called by palpation and one's by auscultation. As you can see with palpation, you're checking the radial pulse, you're inflating the cuff, you've already placed the cuff appropriately, the arrow is pointing to the brachial artery, the cuff is nice and snug on the upper arm, as you see here. You put two fingers on the radial pulse, you inflate the cuff until that pulse disappears, and then you maybe squeeze a couple more times to get maybe another 20 points on the sphygmomanometer. And then what you do is you let the air out slowly and you watch the gauge. And as you're lowering the pressure, when that pulse returns, you can first feel it, the next beat you can feel, that would be your systolic blood pressure. And you document that by documenting it by palpation. So 120 over P or 120 over palp would be the proper way to document a palpated blood pressure. You cannot obtain a diastolic pressure on a palpation. It's only the upper number, the systolic. Now auscultation is by listening, and you're going through the same process, but now you're taking the diaphragm of your scope, you're placing it over the brachial artery, as we described earlier, and you're going to pump the cuff up until you hit, just go all the way up to like 160. It's a good place to start for just training purposes. Go up to 160 and then slowly let the cuff down by releasing the pressure. And you're listening for that first beat. And the very first beat you can hear, very first thump you can hear in your ears, that's your systolic blood pressure. You would then note that number and then continue letting the pressure drop slowly. So you're going to hear thump, that's your first beat. Then you're going to hear thump, 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 and at some point that sound's going to disappear. It's going to be gone. And at that point, when it disappears, that's your diastolic blood pressure. Remember, the systolic blood pressure is the pressure wave. It's the pushing of that blood through your arteries by your left ventricle. The diastolic pressure is the ambient pressure inside the arteries between contractions. So you can't hear a diastolic number. What you're hearing is nothing because the pressure's been equalized essentially. And then of course you would document an auscultated pressure as a fraction, so 120 over 80, 140 over 76. The one thing about these manual blood pressure cuffs like you guys have is if you look at the dial, it goes from 0 to 300. Usually that's the range on these, but each mark on there is 2 points. There's no odd numbers on there. So you cannot obtain a blood pressure of 123 over 75 on that device right there. It doesn't exist. So you always want to document an even number when using a manual BP cuff. Now, I'm sure you've been to clinics or doctor's offices or hospitals and the nurse put a cuff on your arm and they reached over and hit a button and the machine, this automatic computer machine, took your blood pressure. This is called a non-invasive device. Those devices, because they're computer operated, those can obtain odd numbers, and that's okay. But if you're using a manual cuff, like you see here in the picture on what you bought, it has to be an even number that you document. And if you think it's 173 over 91, make it 172 over 90. I mean, is it really going to matter? You just round up or down to an even number. If you put odd numbers on your documentation, that might be questioned. So this is just what I was talking about. You can read through this essentially to obtain a palpated and auscultated blood pressure. I'm done. Normal ranges for an adult male, this is just averages. So if you take 100 plus their age up to 40 years of age, and an adult 90 plus her age up to 40 years of age, that will give you their normal systolic blood pressure. Now, for children from 1 to 10, their normal systolic blood pressure is 80 plus 2 times their age. And kids that are greater than 10 years of age, they should have at least a 90 systolic minimum blood pressure, essentially. And everyone's different. Obviously, lower the blood pressure, especially the diastolic number, the healthier you are, essentially. And you will encounter what appear to be young, healthy people that have high blood pressure. It's unfortunately between our diet and what we do, our society and stress and all that. People do get high blood pressure, but most people should be within normal ranges. What we're looking for is abnormalities. And when it comes down to vital signs in general, we have this normal range that we know. We know that people should be breathing, 12 to 20 breaths per minute. Their blood pressure should be around 120 over 80 on average. So we know we have these averages. And so how that helps us is it allows us to pick out the abnormal things. So it's like a car mechanic. A car mechanic needs to know all the factory set parameters of this vehicle so they can determine what's abnormal in the car and fix it, essentially. It's the same idea. So we have this baseline of understanding that we can pick out the bad stuff, essentially. Now, orthostatic vital signs. Orthostatic vital signs. Orthostatic basically means is the body position. So this woman's laying down on the sofa. She's looking pale. She's maybe having some blood loss or some abdominal pain. You take her blood pressure and her pulse as she's lying on her back in the supine position. You obtain a blood pressure and pulse as you normally would. And then you have her carefully sit up and have her sit there for about a minute if she can. Be careful because they can get really dizzy and even pass out when you do this. But slowly sit them up, see how they feel. If they're feeling okay sitting there, have them sit there for about a minute, take their blood pressure and pulse again, and see if there's any difference. Now, if their blood pressure, this is their systolic number anyway, if their blood pressure drops greater than 10 points, so initially they were 120 over 80, and now when they sit up, they're 100 over 50. Well, that's an obvious positive change for the worse, unfortunately. Also, their pulse, if it rises more than 10 points, that's also a positive orthostatic finding. So she's 120 over 80, she's 70 as she's lying down, and as she sits up, her blood pressure drops to 100 by palpation, and her heart rate jumps up to 100. That's telling me that she's low on blood. She's having problems compensating for that position change. If you sit her up and there's no change in her orthostatic vital signs, you could then carefully again stand them up with assistance. Let them stand there for about a minute, let their body get refamiliarized with that different body position, and then take the vital signs again. If any time through these three sets of vital signs, if their blood pressure drops greater than 10 points, or their heart rate goes up greater than 10 points, or both, those are positive orthostatic vital signs. This is also known as the tilt test. Have you ever heard of that before?